welcome at the live cases afternoon session. We have 4 cases in parallel, 2 at Homolka, 2 at ICAM, all these with FARAPulse technology, but with different imaging options, who will facilitate it, the procedure. And Homolka has been asking to be the first. I think it is the case which will be done by Tom de Potter. So please connect us.
So, hi everybody.
Hi, good afternoon everyone. Can
Hello.
you hear me?
Hello?
Hello?
Yes, we can hear, we can see.
Yes, perfect. We know that we have a lot of cases in this afternoon session, so let me quickly introduce the patient. The patient is 48 years old, quite healthy male with paroxysmal AFib. And the case going to be FARAVIEW PBI plus alpha. That will be the next discussion. So here we have Professor Philip Sommer from Germany, and he's going to be the operator for this case. And please explain what we have done so far.
Yeah.
Yes.
Thanks, Toshi. So sorry, it's not Tom de Potter. I see the disappointment in everybody's faces, but anyway, it's going to be a super interesting case because it's going to be exactly what we just spoke about in the early presentation about FARAPulse with 3D mapping. So we have the new system, the FARAVIEW, which is kind of a combination with a mapping system called OPAL, which you see now on the screen. And we created already, after an uneventful transeptal puncture, a geometry of the left atrium of this patient. So you see the device already. It's a 31 millimeter FARAPulse device, as you see here. And additionally to that, we also connected the wire that is inside this device with the mapping system. So once I advance the wire, you will see that now the wire goes into the left superior pulmonary vein, which you also can appreciate on ice if you look at the probe. And what I'm going to do now is to demonstrate to you how these whitish areas that are kind of the predictors for the lesion where they're going to take place, they change when I'm moving the catheter. So I'm now advancing the catheter a little bit into the pulmonary vein, as you see here. And you can also rotate it. And the goal is that we get more or less circumferential white areas which will be predictive for the lesion formation. Maybe we can rotate the map a little bit, also to the anterior. Yes, and you see that we have a nice, except maybe the carina region, I will try to push a little bit more in this inferior. Now you see that we have got contact basically everywhere. We have nice signals. What we also can demonstrate at this stage is the information that we collected during the anatomy mapping, which is the voltage maps. And you see that obviously we have a super healthy patient, which was to be expected since this guy is only 48 years of age and has a short history of only about 2 years since the first diagnosis of AFib. And on top of that, he has documented typical atrial flutter. So if there's no further questions from your side, I'm going to just quickly go through these left veins with you. And we're going to charge the system now, please, and make ourselves ready for the first application that we deliver now. Look at the electrograms, but you're going to be probably tired of seeing that, but it never gets old, honestly. So within 3 seconds, we got now rid of all the signals in this PV. We give the second application right now. And then the most important thing and the most relevant information that I think that we can get from this system is now the rotation. So I just take the device, I rotate it so that the splines are exactly in the middle of my previous lesions. That is now the case, and we can continue ablating. And I really think that this is something that fluoroscopically guided is really difficult to achieve, to get this rotation done in a perfect way. And we give the fourth application. And I honestly stick very much to the, let's say, rules of the manufacturer. That is 8 applications per vein. So you see that I'm now changing the configuration to flower mode, pushing a little bit in. And now I have good contact. Can you show anteriorly as well again? Just to make sure that we also have white dots there, so we can deploy the left superior and flower, the first one. It's really helpful to have a look at the shadow, which the technician just took, so that I can adjust the rotation in a second application in flower. And then again, now the nice thing that I rotate, and I'm not rotating too much, but also just that I put the device like in the middle of the previous ablation. I think now I'm quite happy. So we can deploy here, number 3. Yes, please. Yeah, I'm pushing a little bit more. I think this one.
It was too much proximal according to eyes as well.
Yeah, definitely. You're completely right. Now I'm in good contact, so we repeat this one. I just did focus myself too much on the rotation and forgot to put it in the right spot back again. So we give another one here. And then we will move on to the left inferior. Again, just looking at the wire, Toshi will help me a little bit by steering the wire, just taking it back and closer to the device. And maybe here he can also advance it. I think it's in. So we advance the device now. We open it a bit to give some sort of push. Let's check with the fluo a bit. So yes, this is okay, I think. Can you go a little bit more to PA? We have PA. I push down a little bit to have all the aspects of this. Yeah, now it's better. I hope that the pulse will be delivered because 2 of the splines are a little bit close to each other, C and D. So we can start delivering here, please. Yes, it's doing a good job. So this was number 1 in basket. Again, signals only far field left. Second one, please. And after having completed the lesion set, here we're going to do a very quick map of the posterior wall, mainly to get an idea of if this is diseased or healthy left atrium. So I'm just counterclocking a little bit, clocking a little bit to get more contact posteriorly. So I think we can go for it here. And the last one for basket, and then we will proceed with flowers. But honestly, I find it super helpful to have this sort of information. Also to have the wire visualized, because again, it will save you a little bit of fluo exposure. So now I'm pushing. I have nice circumferential whitish areas around my catheter. I hope that Dan is happy with the eyes. We don't see it perfectly. Here it's getting better. We can deploy. And before you think it's getting boring with us, I can tell you that we already did the right side, so you don't have to be afraid that you were going to have to watch another 20 applications. Second one, please. So there's going to be just one more rotation right now, like this, and we advance to be in good contact. I think this is a good position. Last 2 applications, please. And then we are already happy, and then we're going to map the posterior wall, and then, of course, as I said, we have to do the right-sided isthmus on top of that, because this guy has documented typical flutter. So that's it. So maybe we can add the right-sided lesions, and we can remove the wire. Okay, where's the wire? Somewhere. Where is it? But maybe it's outside already. Yeah, here we go. Excellent. So let's have a look at the map. So we have the lesions on the right and the left already, and we can start doing a quick remap using our mapping system. So this is inside the PV where we just have far field signal. We're going to collect these red points, as you see. I'm going to go a little bit deeper inside the vein. So this is going to be red as well. And now the key point will be, what is the posterior wall doing? So did we leave some posterior wall to this guy? And you can see it already at the electrograms that there's plenty of purple color still left, with a very nice and sharp transition between the ablated area and the healthy myocardium of this patient. So I think this is far away from being critical in terms of being too much ablation at the posterior wall. I think this is nice and solid. So we're just going to collect a little bit more anatomy. I go to the right side, maybe the wire a little bit back, Toshi, the wire.
Where is back?
It's back, okay, excellent. So we're going to go to the right superior once more. This should be here. Maybe you can try to bring in the wire here.
Where is in?
Does it go in? Yes.
Yes.
Yeah, here we go. So this is right superior. And you see we can do all of this non-fluoroscopically. So we now move the whole system a little bit posterior-wise. We can take the wire back and even try to wire the inferior, which was a little bit more challenging previously. Let's see. Yes, it goes in.
There.
So we can map a little bit here, but you see that the veins are super nicely isolated. Wire back, please, again.
Wire back.
And I show you the, even more. Yes, I show you the rest of the posterior wall, which is here. You can go to almost flower to get this information done here. And I think it's pretty nice and convincing, I would say. So let's just quickly map the left inferior. Maybe Toshi can help me with this. Yes, excellent.
Wires in.
So we just advanced the device a little bit into the left inferior, which is here. But again, here, no signals at all and a very sharp transition. A lot of posterior wall, healthy posterior wall left. We already had the discussion whether this patient may need a posterior wall isolation. All he has was 2 cardioversions and a relatively short history of AFib of about 2 years. And as I said, he's only 48 years old. So if no, like whatever roof-dependent tachycardia would be inducible, I would be very much in favor of not adding the posterior wall to this patient. But this is completely up to you. Maybe you can vote in the panel. I think I see Serge, I see Dan. Would you do the posterior wall, or would you leave this guy with this pretty normal voltage? Otherwise, we would proceed with the right-sided isthmus to close that case already. What do you think, guys?
So please raise hands. What do you think? Would you do the posterior wall in this patient, knowing the clinical history of this patient? Who would do it? Raise hands.
It's a democratic decision.
Nobody.
I'm not gonna do it.
You know I am French, so I need to do it vote. So 0%.
Okay.
Zero.
But
So this
maybe
is not
everybody's
democracy. 0% is not possible.
But maybe this is everybody is asleep. You should also ask who's not doing it, because otherwise it's just the after lunch tiredness of people.
No, I think that they are sincere.
Okay.
They are not sleeping, I can tell you.
They are not sleeping. Okay.
Yeah.
So next step in this patient would be that we already are done. And this is the nice thing about this technology, that we're going to have one catheter with one transeptal, no catheter exchanges, no issues with ever, like getting air trapped or something like this. No mapping catheters, which we have to change forth and back, but just like one dedicated catheter. And now we're going to move the whole thing back to the right side. The wire can go back. And we will try to find a nice position. Yeah, maybe you can go to LAO. And the wire needs to go back. Yeah. So let's see.
Very nice. Okay, we have very nice isthmus on the CTI.
Oops.
CTI,
The device is not nicely deployed, so maybe we deploy it right here, like this, and then we try to bring it all the way down on the isthmus. Okay, so now ice guys, you need to help me.
Yes. You see the CTI on the
You are
ice?
behind the valve.
Yes.
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 Push it in and deflect.
Deflection.
Push in.
A little bit more in, probably, yes. So, yeah.
And even more in. Maybe the under the valves. Push it in a lot. Yeah. I think we're on the other side of the valves.
Okay. So, let's try to...
I think you should release the flower if this is the case, because it will be difficult or almost
Okay.
impossible to get back to the CTI.
Okay.
Pull back. Yeah, pull it. Pull the sheet back.
And, okay.
Pull back even further.
Pardon?
Pull back even further. Yeah. Now let's go to flower.
Okay.
So let's come out a little bit. Yeah. Pull everything back a little bit. Okay. Now it deflects completely. Yeah, perfect. Now it deflects.
Perfect.
Now it deflects completely. 90 degrees. Push in more. Push everything in. In. Yeah, push in more.
Fantastic.
Yeah, in more.
Fantastic position.
Okay, so obviously people like it. You see that this is not our German daily routine to do isthmuses with the Farrell pulse.
Tell John Mixler if he's
Okay,
happy.
so
Ask him if he's happy.
as we are doing CTI,
Let's see the ice.
we are giving
On ice it's easier.
nitrate, 3 milligrams,
Nice AV position.
and phenylephrine.
How much nitrates are you giving? How much?
Yes, nitrates and phenylephrine combination. The patient blood pressure is 120, but will be lower after the nitro injection.
Okay, guys, so you have to guide me. And but I think that, at least to me, it would look quite okay here. So close to the...
Yeah, it is absolutely okay
Pardon?
for the first delivery.
Seems to be nice, yes. You're
I
well.
think it will be blocked.
should be okay?
It will be blocked after 2 deliveries.
Okay.
At this side and then closer to the IVC.
Okay. So we wait 1 minute or after? 2 minutes?
Yeah,
Okay,
one
good.
more minute.
1 more minute.
30 seconds.
Okay, so if I ask Vivid again, it's going to be 10 seconds, but
Shorter and shorter.
Are you giving pure nitrate or isosorbide? Which kind of nitrates are you giving?
Nitrates, yes, 3 milligrams.
Excuse me?
3
Isosorbide
milligrams
or not?
nitrate and phenylephrine.
The advantage of the isosorbide is that the duration is longer. It's efficient for about 10 minutes, while the normal nitrate is 2 minutes, maybe 2-3 minutes.
Oh, you can start, guys.
Yes, we
Okay,
can start.
let's go.
okay, let's go. Okay.
Do the double or triple? Yes, triplicate.
Two more.
We usually give 3 deliveries at the same site. I don't know what is your strategy.
Let's go.
One more application.
Řekni mu, že dáme 3 aplikace.
We normally do 3 applications on the same position.
Yes.
And this
Now,
patient
that's
has a bit more space
reposition
towards the IVC.
So advance
Like,
there,
you can
advance
see
everything, and
on
then
eyes.
deflect aggressively. So push the sheath in more. And yeah. And then pull back.
Now, we're doing like a
Make
stamping
sure, are we
on
too
CTI.
subtle? Can you just clock the ice? Just make sure we're not too subtle. Yeah, it looks probably okay. Yeah, I think that's okay. Good.
Okay.
We're good to
Pull
go.
Okay. So next one.
We're gonna do 2 more regions, but maybe that blocks. You see the signals are split.
You want to do the Powerball after this? Try.
Are you using the
Well-
basket position sometimes in the ICT or not?
Yeah, they just discussed that, so
Yes.
I let myself guide by those guys here.
Yeah.
It's really
now
funny.
Push in and undeflect.
Oh, one more?
No, that was 3, right?
It was 3?
That was
Okay,
three.
that was 3.
Okay.
That changes
So
you,
now-
Philippe?
Pardon?
Yeah.
This
now
is
pull back.
different for you, to let them
Yeah,
do.
it's like
Can you show them? Can you show them Powerball?
Yeah.
Can you
Undeflect.
show them Powerball?
yeah, that's not well.
Yeah, it's okay. So,
Okay.
we can normally make the...
Sheet.
Okay,
Okay.
Powerball sounds
Let me
sounds
give you
sounds
RAF,
fantastic.
okay?
so this is normal, like, basket, Farrell pulse basket. Just, we can squeeze the basket to make it smaller. Oh, yes. To make a small basket.
Go like small affair.
Yeah. You have to give it the other nitro, don't forget.
Máme nitráky.
You see on the ice, an X-ray.
They clock your eyes, push it
So this is the olive position for the ICT, huh?
Right. Now you good position. So we are giving next nitrates because it's been 3 minutes after the last injection.
Yeah, can we have PRAGUE screen to be online PRAGUE screen larger, because we have only a very small screen visible
we'll-
and we can't assess electrograms at all.
back a little bit. Yeah, that's perfect.
Okay.
Okay, let's go ahead and do one left.
Thank you.
This is the ablation.
Yep.
So now see, we are just on the valve with a small basket. Oh, yes, right there. Let's do one more.
There's no doubt.
Can we pace faster just to, I think it's blocked, but it is not,
it's
if we
blocked.
pace faster and prolong the AV, it should be visible.
Okay, you're on a counterclock now?
Okay,
No,
I'll
I
move
don't
the
know.
basket
There
a
is
bit
a
more
fusion
to the
between
lateral.
ventricle and the
You see?
second
Yeah, I
component,
see.
no?
That one is
The signal.
definitely atrium, the first
Maybe
one.
you
Yeah,
can do mapping if you want, but I would
Okay,
just, I
let's
think you're
map.
Yeah. Maybe we can do the quick activation map with this.
So let's take the wire a little bit back. Okay.
You have double potential in 3.
Okay, can we do some activation on the opal? Just here you see the annulus position laterally. We're going to quickly create a map.
Okay.
Can we go back to the mapping, because now we see the PRAGUE online or
Yeah.
only?
Yeah. We're gonna show it to you. Can I have more LAO in the map? LAO, yes.
Right there.
So let's see. So this is superiorly, and this. Let's work a little bit on the color coding so that. Oh, stop stimulation. Now we have something else going on. So too much of.
So left-sided.
Yes, distal is first.
Yeah, but this is
Now
this
it's
is-
changed. Yeah.
This is fib.
Switch.
This is hopefully going to terminate in a second.
Switch to proximal.
So maybe
But I think it
posterior
was-
wall will be the choice.
Yeah, let's give it one more minute, because I think this guy will convert. But I think we saw the atrial signals already during sinus rhythm, that this is probably going to be blocked.
It's changing all the time.
So are we ready to convert? So I think,
Let's cardioverse plus
We told you, Philip, that you had to do the posterior wall, huh?
no, that's the wrong conclusion. No, I don't think so.
No.
Excellent, thank you.
Excellent.
So
Philip, ICAM, you are now in already 30 minutes in online, and
yeah, we
live.
are.
ICAM is requesting to be also there here.
Yeah.
So let's switch to ICAM, and we will come later too.
Yeah, we just finished the map, but I think we are
Yeah,
basically
all right.
done. Thank you, guys.
Thank you.
Thanks a lot, Philip. A great case. Thanks.
Bye-bye.
Yeah, we can see you, and if you.
So Jana will introduce the patient.
Good afternoon to everyone again from the same place for me. For today we have again another case of paroxysmal atrial fibrillation on a Farapulse with ice-guided. And please, thank you. It is a 61-year-old lady. She has been diagnosed with paroxysmal atrial fibrillation in April 2024 in a medication rivaroxaban, propafenone, metoprolol, and ezetimibe, echo normal, and we will continue with the procedure.
So she can show you
Můžeš
Just
teďka.
transeptal puncture was a bit challenging because there was aneurysm of the septum.
Echo, you can see here.
So
Another.
they required some bend of the needle and
Další.
puncture is under ice control quite safe and easy.
Yes, it's a bubbles here.
Yeah,
So the
bubbles
needle is
on
already.
left side.
Another, please. And here is sheet and yeah.
This patient has a
Teď ten poslední.
broad common trunk on left side, and I can show
Here is-
you.
here is
I am
on
now
the
in
review.
left atrium, so you can. No,
Now
this
alive.
is not this is recorded. So you see there is a big trunk. I'm now in left atrium, and I can show you that there is the catheter is pointing towards the superior vein, but the inferior vein is below, and you can see that it's quite big. But we use 31 millimeter big flower to cover both because we can go up and down. And I can show you also from left side right inferior vein. You see here, right inferior vein. You can also measure the thickness of the myocardium as we discussed today. And I can show you superior vein, right superior vein. On the right side there is a pulmonary artery branching. And you see this funnel-shaped right superior vein. But I will go back to right atrium and show you this view which I try to promote today, where you see now this appendage below the aortic valve, and there is a ridge between appendage and vein, and I'm now just sitting with a basket on this ridge. Ridge is being averted towards the appendage, so this is nice position for initial application. So we gave atropine, and we can do. We have general anesthesia. We can do first application of pulse field. So let's go. Okay. One more.
Můžeme víc přispat, paní? Ty držíš echo.
Okay, now we will slightly rotate.
Držíš echo?
Yeah,
Jo.
okay. I will check just okay, like 3 up, and now we can continue.
No, radši.
Can do one more. So now I pull back slightly and make a flower. And now you can see if you just push flower on the ridge, you see that we are touching anterior wall below the appendage or in front of appendage. And we have to rotate our tool more posterior to cover the ridge and also posterior part of the antrum. Now it's optimized more or less. Now it's even better now. So we have nice signals now again because we are covering a different part of this antrum. You see?
The appendage is free now. Yeah.
No, it's slightly more even. Now this is now prolapsing nicely. So let's go here. Signals again are disappearing very fast. Let's go. So we changed a little bit the view to have some.
Maybe sheet.
Okay. Let's go again. So since we covered mostly this anterior portion, where is the ridge between appendage and veins, I will do some anchoring lesion pointing more posterior, slightly more posterior. Okay. Ukažme tu žílu. Now we have some signals again. We are on posterior wall of the antrum. Okay, let's go here. So 2 more applications here. Pak se vrátíme do té
Síně.
praxe.
Do pravý síně. Třetí, ne?
So we can even try a little more, but I think it's okay. Let's go to right atrium with the probe, and we can now deflate the flower.
I just to check on X-ray because it's
If you have
left
any
atrium.
questions, don't hesitate to ask.
it's left side.
Just now.
So I will take a wire out and we will go to inferior vein. To tam ne.
Chceš to v levý síni
No,
nechat?
počkej, tak mi ukaž mi
Počkej,
to.
se potřebuje co přesně. Prosím. Ukaž to septum tam.
We were in left atrium again. So I will show you now that we will point towards inferior vein. Now it's in inferior vein is wire. Can show you X-ray, corresponding X-ray. So because this is a common ostium, the difference is not so big. But now you see that we are on ice. You see that we are touching inferior part of this common antrum. And again, we are against this ridge. If we will check in other projection, very nice. Okay, let's go here. One more. Okay, I will rotate. Okay, let's go here. One more. One more.
Takes time.
We pull back slightly, creating a flower. You see again some signal from posterior part of this antrum.
Now it's nice.
Now it's nice.
position.
Okay, let's go.
Maybe we can see on the echo. Yeah. Okay.
So you see a nice sort of prolapsing a little bit into this vein, which is optimal. So that we have 2. We will rotate. Okay, let's go. 2 more. Right. 1 more. I will try to do some more anchoring. Maybe this is okay. We have new signals, so let's go here. 2 more here. Right. And now we will use a small trick to keep a flower, take out the wire, and rotate the catheter to the right inferior vein. So with the bend of the sheath, we can get.
You are almost there.
No, we are not yet there, but we can get there very nicely, I think.
Yeah.
So we are now sitting a little bit I need to go more inside with the sheath and then try to bring it back like this. Now we are a little
bent.
bit more covering superior part. Try again, because usually it can fit very nicely from above.
Yes.
Now it's better. Now it's sitting, prolapsing again. I will push the wire in to anchor. See, this is now.
There is small superior branch of right inferior.
Yeah. We will cover that, and then we will do the basket, which will cover inferior part of the whole antrum. The antrum is quite spacious, as you can see here. So we have signals here. We have good position. Let's go here to. So you don't need to do always basket first and flower second. You can reverse, because this is the easiest way how to get to right inferior vein, whatever is the size of this vein. So we will rotate slightly. Okay, let's go.
And it is not only easy, but it's also safe, because it's difficult
very
to perforate
safe.
with flower, of course.
Yes. You are right. Safety first. Let's go. I can do now this basket. I can bring it slightly lower. See how now I'm covering the whole antrum. Oops. No. There's not much space here, so I need to release this.
Okay, now.
Okay, we will do here, and then we can try again to optimize differently. Okay, let's do here.
Sorry.
So we cover also the superior part of the, and part is in I will come back again, one more, and we go, I will go outside of the vein and try to come back again with flower, because it was quite difficult here to get to this.
Yes, now.
Now it's sitting perfect almost. I will
Maybe
bring it
bent,
in lower area, and we can do 2 more lesions here.
Yeah.
Wait a minute. Yeah, okay. The wire, it's slided again inside slightly.
Okay.
Now we are filling the whole antrum. So 2 more here. Now I have a wire probably going up. Oh, it's in this small vein. So it was not optimal. I will
Which kind of mistake it was?
remove it.
303? 300. Okay.
So we can try superior vein, and
Yeah,
then
and then
I will go back.
because of time, we are in the, no, the superior is upper. No. We are on a branch.
So,
Horní máš tam hore.
okay.
My jsme v té střední.
This is also, it's interesting to see, you would say that this is superior vein and it's not
X-ray.
superior vein on X-ray. because this is I will X-ray.
Yes.
Because this is a branch of the inferior vein.
Yeah.
So you have to go out.
And now
and,
echo, please.
release.
Echo. Okay. Echo.
Now we are going to superior vein. This is through superior vein.
Yes, this is superior vein. Yeah. On echo, please.
On
yeah,
ice
echo.
you can see that we are in superior vein. We can optimize the position. Okay, now we have nice signal. We are filling the whole antrum. We can go here. Are you still there?
Yes.
Nobody is asking anything, so I
Because
just
we are
checked that.
impressed. Well,
So slight rotation, okay, let's go. 2 more.
Charging is. Jo, uděláme a můžete pak asi možná vedle, když tak tom to ukončíme teďka.
I think we spent only 14 minutes so far. Hopefully we'll finish. So we can do now a basket.
Flowers.
Oh, sorry, flower. I'm already worn out. Okay,
It's more on a carina, yeah.
Yeah, we are covering this carina. I will
No.
make it more straight.
Yeah, now it's nice.
Yeah,
I have
we
a
can-
question, Joseph.
We can go here. Uh-huh.
Yeah, question.
I have a question. Yes. Do you use what the German call the olive at
No.
the entrance of the vein or not?
No.
No. Okay.
It depends on anatomy.
Well, somebody maybe uses, but it depends also on the size of the vein and alignment. Okay, 2 more here.
Yes. The problem with the olive is that you don't know exactly how far you're entering. In fact, you can
just
because
think, with olive you increase the
you have
risk
the
of
ice,
creating.
But if you don't have it, it's difficult.
Yeah, you increase the risk of creating cobra if you are opening inside the vein to some extent. So I move a little bit higher now to cover the roof. Okay, here, two here.
Are you still anchoring on the right superior here? Because we don't
Yes,
see very
yes,
well
yes.
the guide wire.
Yeah, I can show you.
Okay,
that
okay.
where
Yeah. Okay, we see now. Okay. Nice. Very nice.
I intentionally took sheath a little bit lower because to enable me to steer better now. And I
But
can try a little anterior and or posterior.
With this position, you are already doing 50% of the roof, huh?
Yeah, well, 50 not, but 1/3 at least. Let's go here.
Yes.
You see that on ice we are filling this antrum and we are rotated now anterior.
Jo, můžeš.
And maybe one more slightly posterior. It's now a nice fit on ice. I will do one more here, or two more here, let's say.
Ano.
Well, basically that's it.
Now we are going to check the veins
We can check the veins.
and
So
appendage.
obviously there is nothing here in this one. Let me take out the wire. We can go to left veins.
maybe this common trunk, it's enough.
Yeah, it's
And
just
they
you see
continue.
that we are in this common trunk and there is no signal.
Yeah.
And I can create again the flower and go to the right inferior one.
Are you sometimes doing checking for the exit conduction, or it's not needed, in your opinion?
Well, you can do that, but it's usually not needed.
Yes, yeah, there is no potential, so.
Yeah.
If there are
is-
potentials, it is questionable because it depends on pacing output. If you pace
Exactly.
like 25, you may capture all these far fields, and it may indicate that this is not isolated, and vice versa.
No, but I think that we should limit the output at 5 volts.
Yeah.
Limitation.
I'm now inside the vein with this lower lobe of this basket, and you see there is no signal in the whole antrum. So I think we are fine with this. With this case.
I think you should conclude the case just because there will be no need to go back to this room.
Yeah. I think you've seen guidance of eyes. This was interesting case because the patient had this common trunk, which was relatively spacious, but again, if we use a 35 millimeter, we would have more problems to get to right inferior vein, superior. But if you can really place your device exactly according to anatomy, and you could also see from left atrium how it looks like. So it's you have absolute control during the case, so you know exactly where you are moving, what are you covering, and that's I think the main advantage. And this atrium is obviously healthy, otherwise we saw good signals in posterior wall, anterior wall, and the patient has paroxysmal atrial fibrillation. So we feel that we did the case.
Yeah, we are going to check the appendage, and it.
Yeah, we can check appendage
Okay, but
if there is
they
a
can
delay,
continue.
but there is
Yeah.
no delay, I assume.
Okay.
No, it is not there now.
Yeah,
Okay.
now it's
nice.
in appendage.
Okay.
Okay. So
Very
thank you
nice.
very much
Thank you.
for your attention. If you have no questions, or Dan can answer questions because they are already waving on the other lab, so they want to do the case.
Yeah, thank you very much. I think
Okay.
that Tom de Potter requested to be online, so
Okay.
we will switch there.
Okay. Bye.
Thank you very much, Joseph. Congratulations, nice case.
Nemusí být, a my jsme někde zabraný teda.
Hi, Tom.
Hello, can you hear us?
Yes, very well. You're online.
Hello, so
Okay.
I'm here with Peter Pekel. He will start with introducing.
Let me first introduce the patient, and it's be very short. So can we move to the next slide, which show it's a 61-year-old male with arterial hypertension, obesity, body mass index of 36. And he has a 1 year paroxysmal AF, has a normal ejection fraction, relatively small left atrium for a big guy. And he's having attacks despite the propafenone. Can we move to the next slide? It's a AF, generally paroxysmal AF. That's very kind of typical history. And what we started with earlier was the rotational angiography, and Tom will comment on that.
Yep, so next slide. So this is the acquisition we took, and this is actually a very good example of what we discussed a few hours ago when somebody asked, can you do it in all cases? And this is an example of not a great input quality acquisition. This is definitely patient-related factors. The patient is obese. In the lateral views, we barely see anything. But as you will see in a second, it doesn't matter much. The end result is good. So here you see what the segmentation looks like, and you can see there is an immense amount of scatter. You could probably not do a plaque analysis in the coronaries, but to see the veins, it's perfectly fine. You see there, we have a left atrium, we have 4 veins, we have an appendage. We can see everything we need to see to guide our procedure, and we don't need to do more. We don't need to do more. We don't need to increase the image quality or repeat it or whatever. It's perfectly good to go. So we can go to the next slide. And so this is the end result. If we go to the live fluoroscopy now, you will see. There we go. So now you should see the live fluoroscopy with the resulting 3D model of the left atrium in overlay. And so we are ready to navigate. This is an AP view, and so here you might start wondering where our veins are, but if you move to left lateral, you see to LAO, you see there the LIPV appearing. It's quite posterior, the LIPV, but now we perfectly well know what to do. So Peter has a very difficult task now. He has to work in silence, which is very challenging, but he will do a great job. And he's now manipulating the catheter in the LSPV. You can see it clearly. There is no confusion possible. There is no mistake possible. The catheter is in the basket position in the LSPV, and we can start. I'm using a lot of X-ray, of course, now for demonstration purposes. Normally we wouldn't stand on the pedal the whole time, of course. But so now we gave our first application. You see the typical result. The point of this case is, of course, not to show Farapulse PFA. You're all familiar. And after our second application, what we will do for the rotation is move to REO. The people that do cryoballoon will understand this maneuver very well. It allows you to look perpendicular on the catheter, and now we can truly appreciate when Peter is rotating, there we go, if we achieve the overlap we want. So this is an alternative way to achieve what Philip explained and demonstrated. So we make sure we generate the overlap we want to generate, and then we can give the next set of two applications. And so the idea is very simple. Left-sided veins, you look in LAO for positioning. You look in REO to have the perpendicular view to make sure that you generate overlap. And then we will do the same for inferior vein. So in this case, for example, the inferior vein is quite low, as you see. It's also
we'll go with the flower.
Posterior. Yes, of course. Sorry, Peter will do the flower first.
So this would be probably something which I would go for.
Yeah.
That's good. Okay.
Again, we can appreciate on the REO view, we can appreciate, first of all, the position of the catheter. We can also appreciate the fact that there is no overlap, that the petals aren't touching.
Okay, so ablate. Number 6. Number 6. And we rotate.
So the idea here is also a bit to show you that, I think the approach is intuitive. It's not rocket science, of course. I think it's the first time or the second time ever that Peter is doing this. He probably has not looked at X-ray for the past 10 years, I guess.
Yes. I guess, please.
Let's do it here. But, there's no learning curve for this. There is, it's like, I always say, if you have a 3D mapping system, 3D mapping systems are fantastic, of course, but the downside is you need to discover the map. It's like if you buy a car with a GPS, but it has no maps in it, and you have to drive in every street to discover the street map, and the 3D angio, or if you do pre-procedural CT, is the same idea.
So now we will cannulate the left inferior.
The 3D angio gives you the GPS with the map loaded already. You know where the vein is. I don't have to go look for it. And of course, if it's a patient with normal anatomy, 4 veins in the predictable normal position, then it's probably not hard to do it in any approach you choose. The story becomes very different if you have a patient with a very strange anatomy. For example, a roof vein you might very easily miss, of course. You will never miss a roof vein with this approach. You will see it. It's going to be there in the map. The map will tell you.
Number 2.
Again, we're in REO now, so you can see how posterior also the LIPV is, and in REO, perpendicular on the catheter, we can perfectly well appreciate there's good rotation now, there's no overlap of the splines.
Go.
We can start.
Number 3.
And then Peter will go to the flower. So I think the approach is pretty straightforward. We will continue on the left side. We have already done ablation on the right side because we were waiting, but we will after...
Number 4, now we'll go to flower.
After the flower sequence, I will let Peter do the manipulation to the right-sided veins just to show you what it looks like. So here we go with the flower.
Ne. Už je tady na homolku. Bude to končit za chvilku.
Again, perpendicular view.
Yeah.
Perfect spreading of the petals.
Go. Number 5.
Application number 5. We will do application number 6 now. And again, we can rotate. There we go.
Let me find. Maybe
Perfect.
this
So
one.
Too much. If you remember, there was a petal at 12 o'clock. Yes,
Yeah, this one.
exactly. So now we don't want to see anything at 12 o'clock.
Můžeme 7, 8. 7 and 8.
And number 8. And then
So we're finished.
Yeah, so for the clinical purpose, we finish the case, but we will, of course, do the manipulation to the right side to just illustrate to you for the audience, and then we can discuss a little bit what you might find useful. So now, here we go. This is the standard AP view again. You can identify both right-sided veins, but to see them ideally, you go to RAO. You go to RAO so you can appreciate the long axis of the veins. Probably we need a little bit more curve here to enter the vein nicely. There we go.
Okay.
And then we can enter the vein. We can confirm the.
We can X-ray.
We can confirm the isolation. There we go.
And there's nothing, or we've been there, but I mean, you can imagine that.
We did this before, and perhaps.
Also
here, this is what the perpendicular view would look like. You can also here appreciate again the inferior vein being quite posterior, as is typical for the RIPV, of course. And then we can go to the RIPV finally. So here you can appreciate that it's quite low, the RIPV, that we will need good strong curve on the sheet to be able to enter it.
It's the upper branch.
That looks nice. That's the wire in the upper part of the RIPV. And now we can advance. There we go. And also here,
there's nothing.
Nothing to see.
So this is to demonstrate the technology and the manipulation, how if you look at the X-ray, how it can help you to understand. We already did the right side. I believe it makes not much sense to repeat what you've seen in the previous lab.
So I think in general, I think it's extremely straightforward. Again, I don't think the point is to say this is superior to ICE. Of course, it's not superior to ICE. 3D mapping also has nice benefits, but also downsides. And the simple reality is many people are doing X-ray alone Farapulse. And if you do X-ray alone Farapulse, I think 3D angio is a very, very elegant way to understand the anatomy in every view. You don't have to make PV angios, and you don't have to start messing with, let's make another injection and another injection. No, you do one acquisition in the beginning, the image is there, all the information you need is there, and there is no potential for mistakes. There is no potential for confusion. What do you think, Peter?
It's to be honest, to do it the angiography for the first time in the lab, it takes some arrangement because you have to have a free way for the rotation of the angio. It's a big thing, so all the tubes and the things have to go. But I believe that's the matter of kind of doing it routinely. If you decide to go to this pathway, it's probably very doable, and the angio itself looks about 13 seconds to do, and then you're with this kind of overlay on the X-ray. So generally there's real, you never miss a vein because you know it's there and you know the anatomy, and it's there. You're not dependent on the radiology department. You're not dependent on the anything, just having the contrast in the left atrium and having the system that allows you to do it.
But this is what you just said is super important. So if you ever try it, most likely your first case you will make some mistake or do something wrong and have to do it again. And It is definitely something that has a learning curve, but the learning curve is short, 5 cases, 10 cases max, and if you do it routinely in our lab, it takes 5 minutes. But I completely agree, the first time, it's a big deal. It's a big deal and it's a mess and everything is in the way. But very happy to take questions if you have any.
Then probably there are no questions. I have no one as well. Maybe the case was straightforward. I'm looking. No. So
Yeah,
probably,
that's the idea.
should we conclude?
So yeah, we isolated the veins. We checked for the isolation. It's a standard procedure, but you said you've seen that in the previous lab. Here was to demonstrate technology that might be suitable for some, I would say, some labs that do not have access to one or the other technology. Maybe the labs have a good X-ray and they are allowed to do this. And that's what I was in Tom lab, and they do it for every case. So once you get the routine, you get and you can use it to advantage.
All right. Thank you very much for this presentation, and we will switch back to Homolka Hospital, which is
Thank you very
what is
much.
requested.
Requested.
Okay.
Okay.
Requested.
Nice. You are there? We'll be there.
Yeah, but I want to see when we're up. I turn my face.
You are there.
Hi.
Hey. Hello, guys. Can you hear us?
Yes.
Nice.
Perfect. Hi.
There
Good
is
to
only
see you.
one guy. Serge left for ICAM.
Ah, okay, very good.
So Dan is speaking.
Hi, Dan.
Hi,
Good to
Melanie.
see you.
Yeah.
So we already prepared a little bit the case. A 61-year-old patient with paroxysmal AF that has just recently started. He's on beta blockers, and the LA was 43 millimeters on echo. We already did the transeptal puncture. Maybe we can show the fluoro for that. So we did a fluoro-only case, so you see no ice. Coming down an LAO with a nice jump here. And then we always go to aereo. Show the next one, please. Now we see nice movement of the septum in the fossa of the needle. And now go back to LAO again. And it was quite a tough septum, but we made it safely to the side, to the left side. And now we also did just an LAO and aereo angio here that we're going to show you in a bit.
Show?
Where you can see, it's actually a quite interesting anatomy, I think. Can you move on?
Yes.
So you can see here very steep and high left superior vein, and the right ones are even more interesting. If you go to the next one, they're more a little bit parallel than really up and down, very large. So let's see, we took a 31 millimeter Farapulse catheter, and you can see now we positioned it already in the left superior vein. So the approach that we have chosen in Hamburg is the olive strategy. So we're going to do 2 olives, then 4 baskets, and 4 flowers. And what I like to do, I'll show you this, I go really distally to just kind of map the sleeve a bit. And now we see here we have not as much signal anymore, right? So I come back till we have some signal. And so, because I really want to target the sleeves, right? So I think here we can see it nicely. The thing is, if the catheter is too small, it won't let you deliver energy. But I think here it looks really neat. We're deeper inside the vein with a more distal lesion, not really antral, but we want to go for the sleeves with the olive. So I think we're ready to go.
Let's try, guys.
Yes? So we confirm and ablate, and we have all seen this. Nice, looks nice, huh? So again, 2 more, 1 more.
Second basket.
Yeah. Thank you. And now we come back with a real nice basket. And now we're much better. I turn the sheet anteriorly. We have more signal now, obviously, because we come outside. This way you can also really map your signals, because once you start ablating outside the vein, you don't get to see anything anymore, right? So, yeah, perfect. And then another one. Just want to show. Yeah. Perfect.
Okay.
Now we will have to rotate it. So we take an aereo angio of view here, rotate it. Okay? Yeah. So we do this case in deep sedation, so you might see the patient moving a bit. We don't have any paralytics, which I think, no, Yeah,
Okay.
second one, sorry. Yeah,
Second,
you're right,
yes.
sorry. And now we go to flower, right? We have 4. I always need someone to count.
Nice.
We advance it a bit more.
Okay,
We,
no collapsing.
yeah, it look. So this is exactly what we want to have, right? We want the paddles to push back into the atrium. This is how we know we have contact. Yes, the plate. And now, because you all will think, how does she do the rotation? Okay, you can do another one when you're ready. Yeah. Thank you. So now we look at this. So we see, we already saw that it is very on the roof, right? It goes really big up. Now we can see that we nicely rotate it. Now we have 2.5 pedals on the right side of the wire, which was different before. Okay, we can go.
We have signals.
Peter, are you happy?
I'm happy.
Super. Most important thing, huh?
Super.
That the host is happy. Okay, yeah. Yeah. So now what I like to do is I come back with the device, I put it in, and now we leave the wire in the upper vein. No, can you leave it in? Just push in, yeah.
Okay.
And then I like to make a little rotation only, and now come back and see if you find the inferior vein. Come back with the wire, please.
Please.
Okay, advance it again after coming, yeah. Now, can you,
Okay. Still upper.
yeah? No, it's
Still
the
upper.
upper.
Still upper. Still upper. Still upper.
Can I just check a second?
Okay.
Sorry.
Yes.
I wonder if this is a different, let's see, branch. It looks a little bit different, no? Okay, can you now try again if we can go to an inferior? We didn't really see the vein on angio, right?
Okay, so still the same direction. Yes, I
Yeah,
will go
okay.
out. Go out. Okay. Oh, now
No.
jumped.
Yeah. See if
Okay.
there's something. But no, I think this is too low. So let's go again. This was the superior one. Can you go into the superior one again?
Okay. Yes.
Yeah. No, you can't.
No. 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 Okay. Now.
Okay.
Now we're superior.
So we didn't also see the inferior one on the angio, I would say. Now try it again. I turned really posterior. It's quite interesting. So we already said it's a bit of funky anatomy, right?
But there should be inferior because the
Yeah.
superior one went really cranially.
Yeah, very steep,
So
huh?
there's
So can I just check a second? Sorry.
Isn't it different one? Now it's different one.
I wonder, I feel like
Is it
this is a different
one?
vein.
Different
This
one.
is the
Okay,
inferior
yes,
vein.
absolutely.
Yeah, this is a different vein. We all agree, right? The catheter looks completely different. It's probably a short common os here, but this is different. Can we show did we save an image for the first one? No, to show the difference. But we have signal here now that we didn't have before, so it's clearly a different vein. Does everybody agree? Okay, so we do
Let's
the
go.
olive, yeah?
Yes.
Yeah. It's just not, okay,
Okay,
so we have
it's
to open it
typical.
up. 1 second, yeah.
Now it's better.
Yeah, okay. Yeah,
Yes. It's arcing because of wire.
yeah. Okay, and again. The olive. This is the olive.
Olive.
Okay, perfect. And now we go again a little bit more basket, but we already see that the alignment is not so good. Here, I would I want to see if we go to a flower, if we can get a more inferior branch somehow. Like, I'm just curious if this is really the only branch that we can see here for this vein. No,
It's going
that's
now.
not.
Now it's different.
Yeah, this is a different branch, huh?
Okay. Yes.
So I try again.
I will pull the.
So now we have a better, so what we
Okay,
see now,
as a-
we have a much better alignment of the sheet and the catheter, right? Okay, so, yeah,
Let's go basket
Mm-hmm.
now. second
So
one.
they're really close to each other, the veins. It's just like on the right side, right? We will have the same phenomena. Yeah.
And now flower.
No. We
We'll
rotate.
keep this
Yeah.
rotation. Okay.
Yeah,
Okay. Perfect.
perfect.
Okay.
Yeah.
Rotation go up. Okay. 2 more.
Okay, again, we see some movement. We know that we can get the C fibers of the bronchi kind of react to the electrical field, and patients cough when we ablate the left veins, right? So this is something you see with deep sedation. It's not going to help to add a whole lot of sedation to this, because it's not going
It's
to...
much better flower.
Yeah. Okay.
So it's much better.
Okay. That is out. Okay. Yeah. Now we also see the V far field, so we see we're really lower now, right? It's not the superior vein that we had before. And again. And I mean, even if you have maybe, yeah. So now we
Okay.
can use aereo again, just to, you know, adapt
do the
our,
rotation.
yeah, perfect. So now, maybe one spine just went inside. So you don't have so much room here. And 2 splines, you see 2 splines are kind of close to each other, that are now, seems to be flipping here. Wait, I'm just, yeah, this looks much better, I would say. Okay. Yeah, let me check LAO. Now we have a huge far field. Yeah, just a second, and let's see. Yeah, so yeah, I like it.
Just
It's
twice.
coming back. Probably more antral, that's why we have more signal. Yeah, and another one. Yeah. Perfect. And then we just checked with the olive again that
Okay.
we surely isolated this vein. And I think we're good here, right? Everybody agrees.
Okay.
Nice. Okay.
Ready to
then
go to
to
right?
aereo. Yeah. So I always bring down the sheet a bit because I feel like it is a huge sheet. So when I go to the other side. Okay. Now advance.
Okay.
Yeah. Perfect. So we're in the superior vein here. It's clearly a superior vein. So different workflows, right? You could either start an inferior one, like with the cryo procedure, but I'm not scared of a phrenic nerve palsy at all. Here again, I do the same thing. I go inside, see where this electrogram actually starts. I come back a bit. I don't want to be out of the heart shadow for the right vein because of the phrenic. I mean, we know that there's no actual paresis, but yeah, we can start here with the olive. But we do know that we can see, but we can see a stunning of the phrenic, right? So this is something that we want to avoid. So I never leave the heart shadow in RAO, kind of, and signals are nicely gone.
Can you
Okay.
just comment this upper veins, because we have some reconnections on the upper right, upper left.
Yeah, so what you can see with my hands is that I'm really clocking the sheet, right? It's almost looking towards me here. And what we have learned also in Hamburg is that from our early studies, that we saw that there was reconnection on the superior aspect because we have an over-the-wire device that likes to turn posteriorly. And I can just show you this now. So I didn't change anything. But now when I rotate the catheter, you can really see how it's moving inside this vein, right? Like from one side to another. I think you can nicely appreciate how you go anterior and posterior here. So again, I try to go very anterior.
No
Yeah, now we have
signal.
more signal because we're in the basket. We are not in the olive anymore. Yeah. Yeah. Also important to, you know, keep the sheet really backwards when you do this so that you don't compress your basket. And again. Yeah. Yeah. Nice. So we can optimize a little bit our alignment. That's why I'm flexing the sheet, rotating the catheter, turn it anteriorly. Yeah. Okay. Yeah. And as you notice, I do a fluoro-only case, but I only step shortly on the fluoro because I don't want to, you know, there's no need. I'm not worried that the catheter is going to fall inside the vein or anything. I feel like it's pretty stable. Now we go to the flower power.
Nice flower.
So I always try to bend it a bit because we know from the early data also that we can have, this is nice. Okay, now we have 2 up, 3 down, yeah. Because what we know is from the early data that we can easily create an isthmus on the posterior line. So when we're not doing a posterior wall, I always try to bend the sheet a little bit for the right superior vein so that I do not accidentally ablate there. So, moved a bit, huh? And I think this is because we have this huge inferior vein that we know of. Okay, so this is very nice. There's one pedal coming in, so we stay outside. Yeah, this is nice. Okay, 2 more. Yeah. I like how in this case you can really see how the pedals always come back towards the atrium, which is really what we want to aim for, because this indicates contact, right? Okay? Yes.
Okay.
And then what I like to do is to go to the inferior part with the flower shape usually, because it can, we know, yeah, that it can be difficult. Yeah, okay, come back with the wire, please. Yeah, and try to go into inferior. No, here. We know that the inferior is, this is a vein, huh?
Yes.
Yeah, so, and now, yeah, again.
Okay, perfect.
Okay, nice. So because we know that sometimes when we do the transeptal very close to the vein, and then we don't have so much space to move with the basket. As you can see here, it already looks really small, and I can see on the inferior aspect that the septum is pushing away the spline, right? So let's see if it lets us deploy energy. Yeah, yeah. And we already saw this on the angio. It's the same thing. The veins are really close to each other, the superior and the inferior ones, right? So we have already all the far field signal ablated kind of on the superior one. Yeah.
Yes.
Okay. So now we come out. Okay, yeah. Now we have again more signal because we are moving antral, and this way I kind of feel like, and you know, the stunning always leaves me a little bit like I don't know where else to ablate, what to do, but moving from more distal to antral kind of lets me still map. Yep, thank you. Now we rotate. Okay, yeah. So I heard that there was an idea about maybe do put an ice catheter into this procedure and blind me to it and have people see if I was in contact. They luckily decided not to do it. Okay, one more. And I'm happy that you guys make me look good this way.
It's the purpose of the invitation to show no eyes.
So what I'd like to do now, I really want to get the inferior aspect, right? So I really
it's nice
do
position.
it like this. So I get like the, let's see if we get, yeah, perfect. Okay, now again. Because we also know, like with any single shot technology, or maybe we're not always covering the inferior aspect. So we also really wanted to this. And you can again see the upper spline is reaching a bit into the superior vein again. Okay, and then we rotate. We have 3 up, right? So we do a rotation. We still have 3 up. Now we have 2.5. Yeah. Okay. Yeah.
Signals changed. That's good.
And again. Yes. And then we check the vein. I always go back to the olive and check again, and then just that all the signals are gone. Yeah. Nice. Okay. And now we do the last final check. Again, we make this very small and looks very nice, right? So I think we're finished. Anything else we have to do? I think there's another case. Thank you all for watching and for the invitation.
Thank you. Are there any questions from here? I have no question. If you want to ask yourselves,
you put it up.
Ask and answer immediately.
Actually, we pulled the catheter out, so no questions.
Yeah, no, I'm so sorry. It's just
how many?
thing I do.
How many deliveries did you give? How many applications?
40.
Yeah,
total.
40. Yeah, so we do 10 for every vein, right? We do
40.
2 olives, 4 baskets, and then we do 4 flowers.
All right.
And adding the basket, there was a nice publication by my colleague David Schaak and Jackie P. recently that showed that we got the reconnection rate significantly lower. So it was over 40% with the normal approach with 8 applications, but adding the olive and ablating the sleeves, and we think they cause AFib, right? So by ablating them, we reduced it to less than about 20%. So we had half of the reconnection. So I think for us it was very important, and now we changed the workflow. We don't ever leave out the olive.
We frequently adjust the number of deliveries per vein using individual anatomy. So if the vein is really small and easily ablatable, we may end up with 8 deliveries. If it is large vein, for example, right superior, we do the standard lesion and then additional antral deliveries anterior to the Bachmann, posterior to the roof, everywhere.
Yeah, no, I agree. You can definitely probably individualize it. You know, this is a fluoro-only case, so there I think it's important to standardize it because you don't have that many options always, and really being accurate as maybe when you add mapping, when you want to, you know, individualize your lesion set. That's why we go for the workflow in every vein the same thing, because we believe then we're not missing something, right? Because I think with fluoro this is important again to keep it reproducible, and for everyone to do the same thing in the lab, I think we feel is also important, so that we can actually, when the patients come back, also understand did we do a good job, which protocol was used. Yeah.
Okay.
All right, thank you again. And I guess that Philip Sommer wants to continue his case, if it is possible.
No.
Maybe show his.
I have such an information.
Okay.
Yeah.
They have other patients that are done.
So we're really happy over here.
Okay. Yes, thank you very much.
Thank you, guys.
Thank you so much.
It's nice.
Homolka. Yes.
Can they see us or hear us yet? Can you guys hear us? Hello? Can they hear us? Oh, yeah?
Yeah, we can.
Oh, okay, fantastic. So welcome back. We have a different patient, a different case. This is going to be the OptiShot. That's the balloon-based PFA, particularly balloon-based PV isolation with pulse field. So Toshi, you want to just quickly introduce the patient?
Sure. The patient is 61 years old, male, paroxysmal AFib, no cardioversion before. And he has just hypertension. And on CT scan, he has clearly separated 4 veins. And you see, look at the eyes. 2 veins on the left and 2 veins on the right here. So what we have just now is just 2 punctures on the right side, eyes transeptal, and that's it.
Yeah, so it's a minimalistic approach. We literally have just the ice catheter and the transeptal for the PVI. So if you look up on your screen, obviously you can see the ice that Toshi just showed you. Again, the 2 veins, left inferior, left superior, right inferior, right superior. And of course the aorta is behind there. On fluoro, let me just fluoro really quickly so you see. So the only thing, again, you see the ice catheter there and you see a deflectable sheath. So this sheath is a 12 French ID deflectable sheath. It's the same sheath that's been used when this was a laser balloon. And we have the catheter, and so we just did a transeptal with with an 8 French catheter and exchanged over the wire. ACT is above 300, hopefully. Yeah, ACT is above 300, and now we're going to get going. So what we do is, you can see on ice, let's see, there's the catheter. It's sort of entering toward the right inferior vein, right there, I think, hopefully soon. Nope, let me go back here. Yeah, okay. So we're going to enter inside the vein. So you can see on fluoro. And then over here, let's just show them this. So this is the handle. Hopefully they can see this. And then this is the controller right here. So if we push this button, then the balloon is going to slowly start getting bigger. And you'll see on the, in just a few seconds, there it's starting to open up a little bit. And you'll see as the balloon gets bigger, I'm going to fluoro just so you can see it actually get bigger. So there you see it. Okay. A little bit bigger. It's funny that the tip of this seems a little bit funny. Let me just make sure it's, yeah. Okay. So I'm going to get a little bit bigger here. And what we can do is we're just basically pushing up against the vein. You can actually see the left superior up there. You see there? The orientation, the left inferior is what we're in, and the left superior you can see up there. It's interesting, the tip of it is turning. I'm just going to go to a different branch. That's probably good. Okay. I think it's in a sometimes we want to get a different branch and it'll just go to a different location. Okay, I think this is probably good. So you can see the position here, and this is what I meant before. The endoscope helps us position, so I can play with the position, make it a little bit more counterclock, a little bit clocked. I can deflate it, like right now, I'm just deflating a little bit. This allows me to enter a little bit further. And notice that the shape of the balloon, actually let's go LAO because I think they can see it better. So here is the shape, and notice on the LAO view, the shape of it is very sort of triangular looking. But anyway, we have a good apposition here. So we're going to go ahead and start ablating. And basically I have a foot pedal here. I'm going to step on the foot pedal, and then it'll start ablating. Now this patient is not under GA. This is under deep sedation. And he's probably going to cough a little bit. Yeah, he's coughing and talking now. So we're going to give a little bit more propofol. One of the interesting aspects, can we get a bolus here? Okay. You know what's really interesting? I don't know why, but younger patients always seem to have more discomfort. And anyway, but one nice thing is because it's a balloon, we're still in position despite the patient coughing and sort of moving. Each application basically takes about 60 seconds with the current iteration. So we're going to go ahead and we do 2 applications per vein. So basically we're delivering a total of about 2 minutes per vein. He's still struggling a little bit. Did they give another bolus? Okay, good. The ablation itself is fairly boring. We're here, we're just holding pressure and letting it actually deliver. He's sort of struggling. I'm going to just slightly reposition here. Okay, that's good. This is better, I think. I like this better. Okay. Okay, here's another position. Keep going. You notice how it's pulsating, but what's interesting is when we start ablating, oftentimes we'll get better positioning here. Though here, I don't really like this positioning that much. Let's make it a little bigger. Is that 3 or, yeah, okay. Okay, and then we'll go to the superior vein. So I'm going to withdraw a little bit, undeflect the sheath. Whoops. There we go. Now in the superior branch, right? Yeah. We got to definitely make it bigger. We're too far inside the vein. Let's make it bigger here. So you can see the back end of the balloon on the ice image. There we go. So this is a nice circumferential contact again. So we're going to go ahead and ablate again. Let's go a little bigger, Chief.
And maybe the contact is not as, or wedging is not as important or critical as in laser cases, because of course good contact is perfect, but there is probably no need to be as perfect as for laser cases.
Yeah, by the way, he's coughing a lot right now, and this happens sometimes. Again, notice though that despite him coughing, he's coughing still, by the way. Despite his coughing, the balloon stays in position, which is good. Let's show the ice image too. It's a pretty boring procedure, actually. So right now, as I said, so the way the energy is delivered, it's delivered from the splines. And you see the black dots around on the splines? The black dots are approximately the location of the greatest dimension of the balloon. And that's as far back as the ablative part of the splines, the black dots. Does that make sense? Oh, you know what? We forgot about the recording electrodes. You know what we'll do? The next vein, I want to focus on the recording electrodes, and we can see the electrograms and then watch them disappear after the lesion. Let's do that on the next one. Is this 3 or 4?
This is 3.
Still coughing, right? Gave a little bolus more? Okay. So of course we have the patient that has the most amount of coughing now. So we just, that's it, right? Okay. Okay, so now let's deflate. So now what we're going to do is we're going to deflate and then go to the right inferior pulmonary vein. Here I can show the right. So while Toshi deflates, you can actually see the right inferior veins right there. The right inferior is right there, 6 o'clock. The right superior is like around 3 o'clock there, or whatever, 3:30. Right there, that's a nice view. So we can see both of the right veins here. That's the inferior right down there. Okay, so if we look here, I'm going to take this, let's deflect down. I'm going to deflect toward the right inferior. We can see on ice, it's very nice. Yeah, it's right. Oh, now he's really snoring. Okay. So then we advance this. That's in the right inferior vein. Okay, let's go ahead and, whoa, that's breathing. Okay, let's go ahead and inflate there, please. Okay, so we're inflating in the right inferior. You can see here on ice the approximate location of the backhand. Maybe I'll bring it back just a wee bit. Let's keep inflating, Chief. Yeah, that's pretty good, right? Yeah, you can see it right there. Okay, you see the balloon on fluoro there? Now let's look at the electrograms before we ablate. I just want to talk about these. The electrograms that you see on the top, the white electrograms, actually you guys, can you switch it, make the electrograms bigger for a second? So that way they can see them bigger. Can they do that on what you sent? Yeah. So obviously the EKG is on top. The white electrograms that you see there, the ones that are being highlighted, those are distal electrodes. Okay, they're beyond the ablative electrodes. You can't actually see them on the endoscope. And every other spline has an electrode. And we can actually pace. Let's pace from 4-6. Let's see if we can do that, guys. Yeah, let's pace from there. The yellow electrograms on the bottom, yeah, and there we're capturing. The yellow electrograms on the bottom are basically the electrograms from the ablative splines, okay? So you saw that we captured there. You saw that there's some electrograms. Let's go back to the screen that they can see everything, please. Okay, so you see where we are. Let me just show you Flora one more time. Good position. Actually, let's show them REO because then they can really appreciate the... Notice here, if you look at this, let me do a quick cine. Why did it do that? Okay, my cine is screwed up. It's only giving me a single image, Chief. Okay. Okay, there. You can notice that there's a little bit of a contour there. It is deformed there. So here we're going to go ahead and ablate. Of course, he's coughing again. It's unbelievable. He's so reactive. At the end of this, so what we do is, when we do this right now, it's basically each application is 2 foot power presses, and we do 4 applications. Basically 30 seconds times 4, which is 2 minutes. Okay, so that was 30 seconds. Let's look at the electrograms. Can you make the electrograms bigger again, guys, just so they can see that one more time? So notice on the white electrograms, those are distal mini electrodes. There's nothing. We can try pacing again. We're not going to capture anything, but let's pace it one more time. Yeah, I mean, it's going to be, yeah, you can see it's marching across. Notice that, yeah, there's no capture. Okay, stop pacing. Notice also the yellow electrograms. You guys, stop pacing. Okay, notice on the yellow electrograms, these are the ablative electrodes. There's some low frequency stuff because, again, that extends all the way back. All right, let's show them all of the screen again, please. I'm just going to keep ablating. Yeah, good. Okay, let me just put the ice image here. You can see the back end. You can barely see the back. You want to show it to them better, Toshi? They can see the back end. It's just a little faint. The balloon is full of, basically water. So it's somewhat faint. That was 2 or 3? That was 2. Okay. So got 2 more foot pedal presses. So again, we're using a certain dose right now. This is how we're doing the first in human studies. The plan is there's a upgrade to the generator and the waveform. So the expectation is right now we do 2 minutes per vein. It'll eventually be up, I think, 1 minute or something less than that, 40 seconds per vein or something like that. Now, from the preclinical studies, this application is more than sufficient to get durable isolation. That was 3, right? Okay, that's more than enough for in preclinical studies. Obviously, in patients, that's what we need to understand. Acutely, you get isolation very quickly, as you noticed. That's no surprise. And I think I mentioned this earlier in the presentation. We're doing durability studies in all these patients. The other nice thing is, because of this handle, it really is a one-person thing. I mean, Toshi's helping, but the reality is with one hand, you can just make it smaller, bigger, reposition, make it bigger. That's 4, yeah?
That's 4.
Okay, so now we're going to deflate. And there you can see again, by the way, the contour of this. Back to deflate, yeah. So now we're going to do the superior vein. Where are we? Oh, there we go. Okay, so let's pull this and then go to the superior. So that's the superior vein. Let's inflate there. Any questions at all? No? All right. Maybe everyone's really tired at this point. Melanie, you were too fast with your case.
Speaking too fast or?
Being too fast. Okay, so there, let's go a little bigger. I think we can be a little bigger than this. Okay, I think that's good.
That is much better.
So typically what I would like to do is deflect the sheath, clock it a little bit in the right superior, and you usually get a relatively nice circumferential position. So let's do the last lesion. He's definitely going to cough here, if he coughed at the other ones. Oh, wow, finally.
surprise.
He's actually not coughing. All right, that's good. So this is the right superior. You see the position approximately. Obviously, you're capturing the phrenic, which is no surprise. The other thing is, the transeptal puncture is obviously very important for these procedures. What I typically like for the balloon is not to be too anterior, because if you're too anterior and superior, you end up having trouble coming all the way to the right superior. So for me, it's better to be mid-low and pointing toward the left veins. That gives you a nice shot for certainly the left veins, but also the right veins. Okay. This is it's pretty boring. I think everyone's fallen asleep by how boring this is. The other thing I like about this is it is we sort of want to show a minimalistic approach, which is what we're using. So again, you see we're using ice, of course, because we like it for safety, transeptal positioning, etc. But it's really ice and ablation catheter. We don't need GA, so the workflow is pretty nice. The patients, yes, sometimes they cough, but as you can see, it's manageable. Okay, so now the veins are done. So at this point, normally you would be done with the procedure. Oh, I needed 3? I forgot what I did. This is so boring, I can't remember. Okay, I guess I gotta do one more application. I did only 3 instead of 4. Let's go a little bigger. I think I deflated it slightly. So at the end of this application, normally we would be done with the procedure. But since this is part of a protocol, again, this particular technology does not have regulatory approval. So this is part of a first-in-human clinical trial. What we're going to do is we're going to do a map. So we're going to do an electron-anatomical map just to identify the level of isolation. And this way, when we do the remap in hopefully about 3 months from now, we'll be able to compare both we'll be able to compare the level of isolation, whether or not it's isolated and where it's isolated. Okay, so there, let's take this one out. And so since we have what, 5 more, we have 15 more minutes, jeez.
But there is one more case ready in ICAM, so
there is?
There is no problem with excessive time.
Okay, wait, so do I have any more time to do this map, or you want to go and come back, or what's better for you? Well, we can do this fairly quickly. Let's go to
if you have something to show you, we should wait maybe 5 minutes more, because
3-5 minutes should be good.
they are in preparation phase in ICAM. So you have 5 more minutes, or maybe
that's good.
We would like also to know whether the Philip Sommer, how the Philip Sommer finished the case with this, because we left him with some tachycardia or AF.
So Philip's case, if you recall, he had PA and top down, please. He had typical flutter, which obviously he ablated, and then the patient went into AFib, we cardioverted, and then finished the map, and sure enough, it was blocked, as we sort of had seen. Right. Can you go to the cardo page, please? I need to see my octary. Okay, good. So here, we're just going to, can you show them the cardo screen so they can see what we're seeing too, please? You guys, the cardo, this is not cardo. I don't know what the hell this is, but this is not cardo. Oh yeah, okay, this is better. Stefan, can we fix this, please? I mean, we're show a voltage map, please, on both of these. Same settings. It's interesting. Since we're going minimalistic, we don't really have we can't paste the CS. So this actually slows us down. It's very funny. So we have to wait for sinus beats that are not causing PACs, and it's very slow, actually. Can you fix the window, please, so we can see on Cardo where the potentials are? Wow, there's a lot of respiration. So you get the idea, Dan, where the level of isolation is, right? This is sort of what we expect. This is sort of what we want for a paroxysmal patient, I would argue. By the way, who's taking the points? Is it automatic? No, it's not. Okay.
Could you recheck left inferior again?
Yeah, we're going to in
I'm not
just a
sure
second.
about.
Yeah, no, we're going to. Just let me finish the right side. I'm in the left superior right now. I'll go to the left inferior in a second. Show me the left inferior on here, Chief. It's a weird little vein. It's a very annoying vein.
Right there.
You guys, can you delete underneath the left inferior? So that was the left inferior. I know it doesn't look great, but it is the left inferior vein.
Yes.
You saw that. Let me just define anterior mitral region, so that way. Can you guys shave and do this properly? It looks like just one big blob here. Well, you can see where it's just because we don't do respiration compensation in this case, just in the interest of time. But we have to shave there, Dan. You guys see that, right? And let's just define anteriorly. Take a points there, please. You can see anteriorly also. I mean, the level of isolation is actually quite good. And we knew this even from the laser, but because with the pulse field and the location of the electrodes, we actually get good level of isolation. Let's delete there, please, underneath the right inferior. Sort of painful to look at. Rotate up and let's delete again. No, up. Rotate up. No, the other way. In an REO. Yeah, rotate underneath the catheter, please. And delete underneath the catheter. Okay, then let me just finish here. I did another 30 seconds and we should be done, Dan. We got to shave here, guys. Okay, this isn't the best map we've ever done, but I hope you get the idea. Show me a PA view, please. Okay, you guys, you got to shave underneath the right inferior. I can't look at that. Underneath the left inferior. There's just too much respiration. We're not going to get a good map here. Okay, anyway, so hopefully you got the idea of what this looks like. Dan, any questions or comments?
Yeah, we believe that the veins are isolated, that there are no questions, comments, nothing. You told everything during the case.
Okay, fantastic.
Yeah, thank you very much, and we will switch to ECAM.
Okay, sounds good. Thank you.
So you can push now.
Already see you, and we can hear you as well. So
but it doesn't work.
you may start presentation if possible.
Yeah. Dear colleagues, welcome to EP Lab ECAM. I'm Peter Štiavnický, and with Mr. Boleda we are going to present an ablation of persistent AF using cryoballoon Arctic Frog Advanced Pro by Medtronic. Next slide. In this live case, we are going to present a male, 69 years old with BMI 24.7 with a medical history of persistent atrial fibrillation with CHA2DS2-VASc score 2 because of age and hypertension. Atrial fibrillation was first diagnosed in October 2021. 3 years the patient was without any recurrences, but recently he has experienced a series of episodes and undergo 4 electrical cardioversion. The last was at the beginning of this year in January 2025. Patient has amiodarone in medication and atrial fibrillation is symptomatic by palpitations. Patient has normal ejection fraction, no valve disease, LAD about 40, and left atrial volume index about 37.5. Next slide. This is episode of atrial fibrillation before cardioversion, and the last slide shows the baseline sinus rhythm before procedure.
Okay, so hello again. So we will start by the vein. So we'll do PV isolation. We are already in place for the left superior pulmonary vein. As you can see in the tracing, maybe we can go to 100 to see better the potentials. Yes, thank you very much. We can see some sharp potentials here. So there is a fusion between the left appendage
Can we
far
make
field
this
and
ECG
the
bigger,
PV potential.
the main screen ECG?
We will inject here the contrast, and if it's okay for you, I don't know about eyes, but you see that the contrast is quite good. Seems to be a good occlusion.
So we need
We
also
can start
this
freezing on this.
X-ray.
Small
Okay,
X-ray,
we will
small-
see the
small
behavior of the
eyes,
potentials and the
We
tracing.
don't need fluoro.
Well, maybe for contrast.
The temperature curve. You have here on the screen? Yeah. Okay. Excellent.
The beauty of ice is that you can see
So
if there is
a
leak or
slight
not.
prolongation of the potentials.
We see
4,
potentials
5,
large
3,
screen.
4. Okay, I think that maybe it's
No,
no,
it's fine.
now. It's
Yeah, we
moving
see
away,
now
moving away.
prolongation.
And still there. We can see in 7/8, still there. And now this connection. So 55 seconds. We can see if we can see the review screen, please. Yes, maybe display in 50. 50. Yes, 50, then you will see better. Okay, you see here very well the disconnection. If you look to 7/8, you see the sharp potential in 7/8 going away slightly, and then the next is gone. Okay. So here you can say that you have a PV isolation of the left superior
Yeah, exactly.
in less than 1 minute, which is quite good. So what about eyes? Because honestly, for me, it's a discovery. Yeah? I like it.
We facilitate this
Can we
procedure
show
also using ice, and now
ice
we
image?
have RVOT projection showing the position of balloon in left superior.
Nice.
And now I'll change the projection to projection from the aspect of right atrium to see also the left inferior pulmonary vein
Okay.
for the next.
Well, if you use a Doppler, you can see if there is
Usually
any leak
I
of
do
the,
4 minutes.
of the
Usually
flow, of,
only one
or flow
application in
around
this
the
case
balloon.
because we had a disconnection in less than 1 minute. But usually I do 4 minutes. So this is the beauty of cryo, is that then you can discuss with the staff, with your colleague, with the nurses, with the technician. You can discuss with everyone. You can think about your vacation,
Serge,
your
there was
next
a
vacation.
professor,
So-
I don't want to name,
this is once
and,
you are at this point, you know that you
Neuheim,
can prepare
and
for
he
the
was
left inferior.
he was
We
smoking
saw
in
with
between.
eyes that the left
He was
inferior is very
freezing
close,
and went out
so
for some
it
puffs.
should be a
and
very
then came
simple
back
movement,
again.
just bending a little bit the sheath and going a little bit clockwise because the left inferior is always a little bit more posterior. So we'll do this slight movement, and then we should be ready for the left inferior. In the left inferior, for cryo, it's advised to do as much as possible the hockey stick positioning in order to obtain a very axial pressure on the balloon. So hockey stick for the left inferior is, in my opinion, when it's possible, is the best to do. We can see very nicely with the eyes the balloon here. It's very nice. I like it a lot.
So maybe we can change the position for left inferior vein.
You mean for eyes or
No, with catheter.
but now it's deflated? No.
Yeah. Okay.
We're not.
How much?
3 seconds. Okay. 1 second. Okay. Now it will deflate by himself. So we should still have. Yes, we still have the balloon inflated. So now this is the thawing phase what was the minimal temperature that we reached? Minus 47. It's not too bad. It's okay. I think minus 47. What is less than minus 40, minus 45 is okay. Ideally, I want to reach minus 50, but okay, minus 47 is not bad. Okay, so now the balloon will deflate automatically. Yes, you see on the ice the deflation. What is advised is to inflate and deflate again by stretching. You can inflate, please. And okay, we see the inflation on ice. I stretch the balloon and now we deflate. Okay, now I place the balloon inside the sheath. Let's see. I help myself a little bit with the fluoro.
Yeah, you jumped into.
I jump into the left inferior, I think. Huh?
Yeah, definitely.
No, we are in the superior branch of the left. Okay, now?
Yeah, that looks good.
Okay. So I progress a little bit with the balloon. Going push-pull here. Okay. Okay, we can inflate. Inflation. Okay, balloon is, we have a pop out here. We will push towards the roof and we will bend a little bit the sheath in order to obtain a hockey stick here. Yeah, it's not too bad. We go back with the achieve in order to obtain PV potentials. Yeah, we have some potentials here, I think, especially in 7-8. Nice, I think. Okay. We inject the contrast just to be sure that we are occluding. Okay, not too bad. Okay, freeze. Do you like with ice? It's okay for you?
Looks good. I also
You may pay from CS12 to have the signals better, just to assess the PVPs.
Okay. We have some separation. Yeah, you see here now. In 1-2, in 7-8 we see very well. Okay, prolongation. 2-1, 2-1 block, and now it's gone. 2-1 and disconnection in 30 seconds, about 30 seconds. So you see with hockey stick, usually it's very efficient. As you can see on the fluoro, the hockey stick is here is quite nice. We can see it very well. I am in AP. I am used to work in AP because this is the fault of my friends from Bordeaux, from Michel Aissaguer, who teach me to work in AP. So I am used to that. But you can see that the position is quite nice. We have a nice hockey stick, so the distal part of the sheath is in the same axis of the balloon and of the achieve. And you can see that when you have this position, usually the disconnection is 100%. Meanwhile, not to waste the time, we can prepare the phrenic pacing.
Yeah.
So maybe we will place the catheter for pacing phrenic. Minus 38, yes. Here I will need a little bit.
Okay, so we
Pull
have
back. Minus 38, yes. It's not decreasing too much because we are close to the mitral. And I don't know if this patient has some degree of mitral regurgitation, but sometimes the temperature is a little bit higher in the left inferior. This is not very strange, huh? Something that we can see. So we are prepared to pace. Did you test the pacing?
yeah, please, phrenic nerve. Okay.
It's okay?
Yeah, perfect.
Perfect.
Yeah, good
Okay.
capture.
Okay, minus 39. It would be nice to reach minus 40 at least. So whether this connection in 30 seconds in this vein, I think that, again, one application is enough. We will have 4 minutes application here. And then we'll move to the right inferior.
Do you have any trick for right inferior vein? Because I assume that this is the most difficult one because of size of the balloon.
Yes. Usually I try to do a transeptal a little bit anterior, but this is very controversial because some people like to do it more posterior to engage directly the right inferior. I like to have some space to engage the right inferior, so this is why I'm trying to do a little bit anterior. But then it's very similar to what you do with a far-wave catheter. The movement is very likely that what you did in your case, Joseph. Just you rotate clockwise. You will see. You rotate clockwise. You enter with the Achieve, the mapping catheter in the vein. Then the tips and tricks is not to inflate the balloon inside the vein, because if not, if you do it, you will go out. You will be rejected. You will go out from the vein. However, so we will inflate and deflate here. You will see. The problem is that sometimes you think that you need to go far with the right inferior. Yes, deflate. And you will see that you very often need to be very medial in front of the spine, in fact. Okay, I will enter this. I will go clockwise. I bend, I go a little bit counterclockwise, then I push a little bit the Achieve. Okay, we're inside the right inferior, so I push a little bit. You see, I stay out. You see, I am just in front of the spine because, okay, probably with the eyes you have even more information, but I am not used to eyes, so I do the way I'm using to do. You see that I will inflate outside of the vein. You can inflate here. We will have some degree of pop out, probably. Not too much, you see. Okay, I will bend a little bit the catheter. I will orientate this way.
Now you are in.
Yeah, it's not too bad, I think. I will go out with the Achieve to obtain PV potentials here.
Nice, it looks like nicely.
We don't have too much PV potentials. I will try to
Can we see electrograms again, Pruka?
Yes, I don't see too much the PV potentials.
Maybe you are too deep with the Achieve.
Yeah, probably, yes. We are a little bit too deep. I'm going back. Yeah, the Achieve is going very far inside the vein, so this is why we don't have it. Let's try to. This is far field, but this is not PV. Okay, I will go out a little bit out, then I will try to deploy the Achieve in a different way. Still no potentials here. No, I don't see it. Usually we can have it better, but not here. Let's try to go a little bit out. Maybe we are too much inside. I will try to move it in a different way. We'll try to have a loop in front of the balloon. No.
Let's see if we have an occlusion here or not. It's not a perfect occlusion, huh? And this is strange because let's try to go a little bit out. Okay, here I have some potentials. Okay, I push a little bit now. Yes, now you can see the PV potentials here. Here we are. We have PV potentials quite nice. I will try to see if I have an occlusion here. Okay, not too bad, huh? What do you think with ice? It's okay for you?
According to ice, it's good.
It's not bad?
Yep.
Okay, we can do an application here.
Pacing.
No, I would pace at -20.
Oh yeah, okay.
It's not necessary to pace too soon.
Okay.
Okay, we are freezing. Okay, we had some modification. Okay, you see it's moving. Okay, gone. Disconnection, -20 degrees. Now we pace at -20. Yes,
Yeah, pace.
Thank you. Okay, you can display at 50. So you see it's very important to have the PV potential because in this case, for example, you are checking the frame.
Yeah,
okay.
I already
Okay, no,
got
sorry.
captured.
I'm a little bit nervous because I don't control everything today, so it makes me a little bit anxious, but it's okay, that's perfect. So -40, very good temperature, but you see, in this case, for example, we saw that we could disconnect with -20 only, -20 temperature. So it's very nice to have the PV potential. I really believe that this is the beauty of cryo. And we could see real-time disconnection. So you see, three freezes, three veins disconnected. Let's hope that for the superior it would be the same. Eh? And then we will do a roof line. So temperature is good. You see that the temperature is better in the right veins because we are a little bit far from the mitral here, -47. I think that maybe we will reach -50 in this case. Yes, 110 seconds. The phrenic is perfect.
Yeah, we have good capture.
And the patient is not complaining, huh?
No, not
No,
everything's okay.
Okay, it's okay. Nice. -48. That's a good application. You see, it's worth to fight a little bit to see the PV potential. In this case, it was not easy because the tracks are very proximal. But the tips and tricks here was to go back, to make the loop at the entrance of the vein and push again the balloon. I was nearly out of the vein when I deployed the loop because when the balloon was too much at the ostium, then the achieve was going too far inside the vein, and then you couldn't see any potential. Then when you have this kind of situation, you go nearly out. You take everything out of the vein, then you do the loop, and then you push again. A little bit the movement that you are doing with the basket of pulse for the inferior. It's very likely. Honestly, I really feel that the movements are very similar. I don't know if it's also your impression, but at least this is what I feel. 200 seconds, perfect. Nice temperature, -50, that is perfect. For the right inferior, this is very good. But I like to work with ice. It's really nice. For me, it's a novelty. Thank you. It's nice.
This is a big achievement for us.
Yeah. And for me, even more.
Okay, 240. So we will go for the right superior now. We can stop pacing. Okay, yes, that's good. So we will wait the balloon deflate by itself. So thawing, 7 degrees. And you see in AP again, if you look to the fluoro, the balloon is really nearly on the spine, for the right veins. This is sometimes we go too far, and this is why sometimes the right inferior and the right superior are a little bit more challenging, especially the right inferior for some of our colleagues. So inflate again, please. I stretch, deflate, okay. Deflation, okay. We go out, we go everything inside. Okay, yes, I will go. So now I will put the sheath straight. We'll go a little bit clockwise to go to the superior. Okay, we're in the superior.
Yeah, looks good.
I will push a little bit the balloon. Okay, you can inflate, please. Inflation, yes. Okay, I bend a little bit. Something that is very important, you see again, is to be on the same axis with the sheath and the achieve. Now again, I will come back with the achieve to make a loop just in front of the balloon. Here we have nice PV potentials. Yes, they are already separated, you see? By the previous application, you can see the PV potentials. There is a delay that is due to the previous application to the right inferior. We have ablated a part of the right superior at the same time. Yes, you see good contrast injection. Okay, freeze. So we pace at -20.
Jo, dobrý.
Maybe something moved. Yeah, maybe something moved. Okay. I think that maybe the balloon moved a little bit here. Okay, disconnection. Disconnection in 25 seconds. Yeah, can you go in 50? 50 on the screen? No, on the review screen, sorry. Sorry, excuse me. Little bit back. Okay, you will see the disconnection. A little bit back still. Okay, see here, very nice.
We see this review screen.
Yes, you have a prolongation, PV potential, prolongation, PV potential, and then it's gone. Maybe dissociated. I think it's not dissociated because the activation front is the same. So the next one, I think, is conducted with a very long delay and then out. So 20 seconds. So 4 applications. This is the real single shot. There is no other single shot, in fact, that exists for the moment. 4 shots, 4 PVI. Now we will go to the roof when we finish this application. And for the roof, what I used to do is to anchor the achieve. It depends. When I see the anatomy, sometimes I start from the right superior, sometimes from the left superior. In this case, I think that maybe we will start from the right superior. This time we push the achieve because we don't need to see any potential, of course. So we push the achieve quite far in order to obtain a very good stability of the balloon. And then we will go counterclockwise with the sheath, bending a little bit the sheath, going 1 application, 2 application, a little bit more counterclockwise, 2, 3, 4 applications until the left superior. Sometimes, when you have a V shape of the roof, because this is something that happens quite often, you have the roof that is going from the veins up to down, from the right and from the left. So you have what I call a V shape. In this case, very often you need to do the right part from the right and the left part from the left. because it's very difficult to obtain a good stability from the right vein anchor when you go to the left side. Then you have to change the achieve, it's not a problem. We will see here how it goes. 3 minutes, okay. Phrenic is fine?
Yeah, perfect.
Okay, perfect. Very nice. Okay, minus 54. So for the right veins, we had very, very nice temperature. No doubt, this is very good. Okay, we are done. So done for the veins. We will go for the roof when the balloon deflates. So I don't know if ice will be useful for the roof. What do you think?
We'll
I
see.
don't know.
Now I have a projection from SVC to right superior vein, which is not so echogenic as previous, but we can see sharper margins of bone. But we see according
I think
to
if
your
you will go
position.
to left atrium, you can see nicely.
We will see. We will see if it helps. Okay, we will deflate the balloon now.
Now I'm in the left atrium.
Might be visible also from right atrium.
And also
Okay,
very
balloon
good
is
view
deflated.
for roof is to engage coronary sinus, but it can't be achieved in all patients. It depends on anatomy and many other things.
Yeah, of course. Okay, I will push a little bit the achieve to obtain more stability. Okay. Now, we can inflate the balloon, please. Yes, inflation. So you will see, so now you see the balloon is inflated at the antrum of the right inferior, of the right superior, sorry. I will bend a little bit the sheath and I will go a little bit counterclockwise. You see, this way. You see, to move the balloon towards the roof. Okay, now it's moving a little bit. I will try to find more stability. Can you see the contact of the balloon or not?
I'm trying to show projection from coronary sinus.
It seems to be in contact, huh? Yeah, it's not bad, huh?
Maybe now we can see.
Okay. So I would go for one first application here. So I'm going a little bit counterclockwise. You see that the balloon now is really in the middle of the spine. We don't have the CT scan here, but at least it gives us, yes, you can freeze, yes, please. Thank you. It gives us a position if we are comparing the position with the spine. You can see that it's quite stable. We have a decreasing of the temperature, -5, -7, -10. Okay, it's going, yeah. I think that here in this position we are doing at least nearly the half, the right half of the roof here. And you see that the sheath is a little bit bended, not too much, but a little bit. And I'm giving a torque with the left hand, a counterclockwise torque. Okay, you can see that obviously the temperature is not decreasing in the same way that if you were in the veins, huh? It's -30 only. As I was saying this morning during the presentation, I tried to obtain -40. but it depends obviously on many factors. You are not occluding anything, so it's you want to.
We lost the position of CS. Now.
3 minutes only for the roof. 3 minutes.
Okay.
So 180, we can stop at 180. Okay, we can see the balloon here. Huh? It seems to be in contact, huh? No, what do you think?
Yeah, definitely. Yeah, we say sharp.
Yeah. Yes,
sharp
it's in
border of
contact. Yes.
bone.
I feel with my hand. I feel the movements of the atrial systole on the sheath. Huh? I can feel it. Little bit, obviously, not. But yes, we can feel it. I maintain with some pressure. The temperature is not decreasing too much, -33. Okay, we'll see. What we'll do at the end is to check with the chief if there are some potentials remaining on the roof. Yes. Okay, we can stop. So we will wait to the deflation of the balloon. Okay, balloon deflated. So I will go a little bit more counterclockwise with the sheath. Okay. You can inflate, please. Yeah. Okay, so you see that now I am on the right side of the spine. So the right or the left, as you want. Okay, we can freeze here. I feel also good movement. You see it's moving with the wall. Huh? You see that the balloon is moving with the wall. Can you see it also?
Ice.
Yes, okay, so freezing. Okay, temperature is decreasing. Quite well. Oh, I think that something moved. No, it's okay. I felt a movement, yeah. Okay, -32. I think it's a little bit better than the previous application, I agree. Yes, it's decreasing a little bit more, yeah. I think that we have dissociated potential. You see on the mapping catheter, you see the sharp potentials. These are dissociated potentials from the right superior. Yes, you can see here. Huh? It's nice. Dissociated PV potentials. -36, okay, not very low, but this is what we have. So you see we are now on the right part of the spine. I think that we should do at least one additional application, a little bit more towards the left, and again giving a little bit more counterclockwise to be really posterior.
Serge?
Yes.
I think we are half an hour behind the schedule.
Sure.
I think you nicely showed this strategy, and also I'm impressed. I don't use cryo, but I'm impressed how fast it could be. And this roof I would certainly try with this balloon also, and with the guidance of ice, I would try anterior line, because I feel that it should not be so complicated to do it. So it's an interesting concept.
Okay, Joseph.
Any question from the audience?
So next year, Joseph, you will show me for the anterior line. I will come back. You will show me.
Okay. Okay, if there is no question, I think we would like to thank you very much for nice unplanned today case, and see you in the evening. Oh, there is a question. Okay. Okay,
yes.
One question.
Is there a question?
Verify the line at the end.
Yeah, he
Excuse
was
me?
telling that, but you can repeat. How you verify the line?
Yes. I will check. It's not a very, let's say, accurate verification. However, I swipe the achieved catheter on the roof at the end, and if I see still some potentials, I give an extra application. So it's not a completely verification. If you want to verify the line, if you want to check that you really have a complete line, you need to do a 3D map. There is no other solution, because I tried to pace. Doing pacing maneuvers is impossible because the line is so large that you have to place the catheter very, very low in the posterior wall. And even though sometimes you don't have potentials enough to really understand if you have a block or not. So with me, for pacing maneuvers, it's impossible to check the line. You can assess more or less with a achieved catheter, checking for any potentials remaining. But if you want to do it really in a true way, you need to do a 3D map. There is no other solution.
But if I can just comment, I mean, the roof is very small in average atrium. So with the balloon size, if you do 3 applications across this area, you overlap significantly in each position. So I think
absolutely
it should be blocked always. I mean, after 3 applications like this. So.
Absolutely, Joseph. I completely agree with you. This is the problem of the dimension of the balloon. This is a good thing, but this is also the problem for verification.
Okay, Serge. Thank you again, and see you in the evening.
Thanks a lot. See you. Yes, please inflate.